Awesome. Great. Well, welcome. It's such a pleasure that there are so many people joining us, and I'm so happy to be here today to co-host this webinar. Welcome everyone to this webinar from the Journal of the International AIDS Society special issue, which was entitled Growing Older with HIV in the Treat All Era. I'm Heidi Crane, and I will be one of the moderators for this webinar. I'm so very pleased to be here with my fellow guest editors from this Growing Older with HIV JIS special issue, Rina Rajasuriya from Malaysia and Agri Samir from Uganda. First, we'll start with just a little background. I'm a professor of medicine in the Division of Allergy and Infectious Diseases at the University of Washington and associate director of the CFAR Clinical Epi and Health Services Research Corps. And I conduct research on ways to improve effective management strategies for patients with HIV in care. And in particular, I focus on the chronic complications of HIV, as well as substance use and patient-reported outcomes to improve care. I'm pleased to be here with Rina Rajasuriya, who is an associate professor in the Department of Medicine from the University of Malaya and an adjunct research fellow at the Peter Doherty Institute for Infection and Immunity from Melbourne University, Australia. She's also a principal investigator for the Center of Excellence for Research in HIV from the University of Malaya, and she coordinates the translational research program in HIV immunology there. Her current research focuses on the immunopathogenesis of aging in HIV and its impact on health outcomes. In addition, we're pleased that Agri Samir is a Ugandan-trained physician and researcher is here with us today and one of the editors of the journal supplement. He obtained his qualifications in internal medicine from Makerere University and epidemiology with implementation science training from the University of California, San Francisco. He's involved in research projects on the epidemiology of chronic comorbidities, especially cancer and cardiovascular disease, among people with HIV. And his research focuses on prevention and early detection of comorbidities using epidemiological methods and implementation science-based approaches. Next slide. I will ask that as we're going through this, please ask your questions to the speakers and panelists in the Q&A box. Please use the chat box for any technical issues or general questions. And then the special issue, the link to the special issue is up on the slide right now. And I wanted to just talk about the special issue for just one moment. I do hope everyone will take a look at that supplement. We are so pleased to have speakers today from 3 of the articles here today for this webinar. There's actually a number of terrific articles in this issue. And in particular, there were several themes that came through that I particularly appreciated and want to mention. The first is focusing on the inclusion of research across a range of regions and countries with a real focus and intentional approach of including work done in low and middle income countries. The second is a focus not just on comorbidities or physical health, although that is absolutely throughout and is very important, but also a little bit of a better inclusion on health-related quality of life and some of the social factors that our patients are facing as they're aging with HIV. And finally, the focus on not just lifespan or mortality, both of which are important, but also on health span. So living well in addition to just living longer. So let me introduce you to our first speaker, let me introduce our panelists first, and then we'll go to our first speaker. Our panel discussion will be joined by Kenneth Mayer, Editor-in-Chief of the Journal of the International AIDS Society, and by Jules Levin, the Executive Director and founder of the National AIDS Treatment Advocacy Group here in the United States, providing HIV education, information, and aging with HIV advocacy. Jules has dedicated the last 17 years to advocacy, policy, and education around aging with HIV, and we are so very happy to have him. In addition, I've already introduced the co-editors. We also will now switch to our first panelist, our first speaker. My apologies, I said that very poorly. Our first speaker will be Kate Merzen. She's a health program specialist at Realize Canada. In this role, her objective is to build and nurture collaborative working relationships between the HIV, aging, and chronic illness sectors, leading to joint initiatives which improve the health and quality of life of people and communities aging with HIV. We're also joined by, I believe, Rasha Surya is answering questions in the chat, and Linda Orapabal is also here as well. And we'll switch back to them in just a minute.
My name is Kate Merzen. I'm the health program specialist at Realize in Canada. Thank you for inviting me. I really do appreciate being here. I also want to just acknowledge that I'm currently on the traditional territories of the Erie, the Neutral, the Huron-Wendat, the Haudenosaunee, and the Mississaugas, and neighbor to the Six Nations Reserve here in the city of Hamilton, Ontario, Canada.
Sorry.
So during my brief talk today, I'm going to tell you a little bit about the Panache Ontario project and the value of engaging older people living with HIV in community-based research on HIV and aging, and the importance of research as a tool for changing policy and practice to address the unmet needs of people aging with HIV. So I'd like to first just acknowledge the Panache Project funders, the Canadian Institutes of Health Research and the Ontario HIV Treatment Network, my co-principal investigator, Dr. Sharon Walmsley, and all of the members of the research team, and most importantly, the research participants for their willingness to share their living expertise. Panache, the project title, is an acronym for Preferences and Needs for Aging Care Among HIV-Positive Elderly People, which essentially tells you what the study is all about. The overarching purpose of the Panache study is to gather data needed to advocate for equitable access to comprehensive health and social services that respond to the self-identified needs of older people living with HIV. Today, I'm going to be discussing the findings of the Panache Ontario sub-study, which we conducted to describe the health and community care needs and preferences of a diverse group of people living with HIV age 60 and older, and the life course experiences that shape their needs and the extent to which they're being met. So pairs of trained community researchers, older people living with HIV, co-facilitated 9 in-person focus groups in 2019 in 7 municipalities across the province. 5 of these groups were open to all people aging with HIV who were over 60, and 4 were conducted with key populations of older adults living with HIV. Our semi-structured interview guide explored 7 themes with an emphasis on social determinants of health. So this is a brief introduction to the Panache participants, and I'm not going to go over all these characteristics because we're limited for time. But what I will point out is that the research focused on people age 60 and older, not people age 50 and older, as many other HIV and aging studies do. Our focus group participants described varying needs ranging from basic survival to community inclusion. Affordable, safe, secure housing and healthy, plentiful food were the most cited needs, often coming to the fore because they were partially unmet. Participants reported accessing a variety of health and support services, but not all participants' needs were being met, even so. Barriers to fulsome service access included social determinants of health, including inability to afford uninsured services, including vision and hearing services, dental work, and certain vaccinations. Provider issues, for example, concerns about confidentiality or concerns that there was a lack of knowledge of HIV and aging among the providers. And systemic and structural challenges, for example, different silos of care, subjective assessments of eligibility for certain services, and lack of just-in-time responses. Workarounds were often being used by participants to partially address unmet needs, and participants described a variety of individual strategies they used to cope with financial shortfalls and limited access to supports. During our analysis, we noted that older adults living with HIV, especially those living with HIV for a long time, shared in common a triad of experiences: trauma, stigma, and fear and uncertainty. And those experiences intersected to undermine the normal aging process. These lived experiences were shaping the aging care and support needs and preferences of our participants. I'm going to focus on the uncertainty aspect today. So many participants reported changes in memory and concentration, had questions about whether they would expect to further decline in terms of health, had unknowns related to future care and support, including who would take care of them if they remained at home, Some lacked social capital and relied on community-based services, but they weren't sure that those services would be able to respond to their practical needs as they aged. And many were fearful that their pension or income wouldn't be enough to support them. There was a strong preference for aging in community, but many questioned the suitability of their current housing. And there were concerns raised about the need to hide sexual orientation or HIV status if relocating to a senior's residence or long-term care center because of fear of stigma from other residents and staff. So just to say a few things about Panache, it was first and foremost a community-based research project. So half of our research team of approximately 35 people were people with lived experience of aging with HIV, and their expertise was highly valued. We've invested the last 3.5 years in laying the groundwork for a national needs assessment that we're about to conduct, developing inclusive and mutually respectful relationships with all stakeholders across the team. The active involvement of older people living with HIV contributes to strengthening both the outcomes of the research and the experience of conducting it. Several research participants in the Panache project described feeling ignored by organizational and governmental decision makers because of age and the associated stereotype that older adults are no longer active contributors to society. And engaging older people living with HIV in our research project helps counter that perception. A core principle of community-based research is social action. And our community report, which is available on our website, we included a number of different policy and practice recommendations that we'll continue to translate for use by decision makers. On a global level, a new network, iCope HIV, the International Coalition of Older People with HIV, is also calling for change to improve care, quality of life, and empowerment of those aging with HIV. This group, founded in partnership by Realize, NATAP, EATG, and Utopia BXL, launched the Glasgow Manifesto in October, imploring stakeholders worldwide to respond without delay to 10 calls to action that will meet the needs of older people living with HIV. And I look forward to discussing Panache, the Glasgow Manifesto, and other grassroots and community-based efforts during the panel discussion. Thank you all, and sorry about the technical difficulties at the beginning.
Awesome. Thank you so much for such a great presentation. Our next speaker will be Linda Orpable. Linda's a trained pediatrician, now working as a clinical research at the Research Institute for Health Sciences in Chiang Mai University in Thailand for more than a decade. Her interests and works focus on HIV treatment and complications in all age groups, from young children and adolescents to aging people living with HIV.
Good morning, everyone. Today, I would like to share our study at Chiang Mai University on the topic of neurocognitive performance and quality of life of older adults living with HIV on antiretroviral treatment in northern Thailand. In Thailand, the national scale-up of HIV care began in 2000, and now we have many patients on antiretroviral treatment who have survived into their 50s, so-called older adults with HIV. Neurocognitive impairment, or NCI, is one among several comorbidities associated with a decline in daily living activity, cognitive symptoms, and functional status in people living with HIV. In the ART era, profound HIV-associated neurocognitive disorder was less frequently seen, but minor forms of NCI remain prevalent. The consequences of NCI include poor medical adherence, disruption of functional daily living, decreased quality of life, and increased risk of mortality. So our study objectives were to determine the frequency of NCI among Thai older adults on antiretroviral treatment and correlation between neurocognitive performance and quality of life, and also identify factors associated with NCI in older adults. We conduct a cross-sectional study in 12 community hospitals in Chiang Mai, Thailand between September to November 2020. Our study population were older adults who were enrolled and followed in the prospective cohort of older adults, started in 2015. They received HIV care Under the National AIDS Program, which covers antiretroviral treatment refilled every 2 or 3 months, CD4 count and laboratory safety parameters were measured every 6 months and annual HIV viral load. All participants who show up during the study follow-up in 2020 were invited to join this study. So for the data collection, we perform cognitive performance assessment by trained investigators using the Thai version of Montreal Cognitive Assessment or the Thai MOCA. The score below 25 was defined as having NCI. The score between 16 to 24, we call it amnestic mild cognitive impairment, and below 16 is dementia. And for the health-related quality of life, we access that by Thai validated version of medical outcome study or MOS-HIV. Higher score mean better quality of life. And we calculate T-score and physical health summary T-score of above 50 were defined as good quality of life. So in totally, we enrolled 269 older adults into this study. 60% of them were female. The median age was 62 years. 60% age more than 60, and 80% of them received 4 years of formal education. The median time from HIV diagnosis to ART initiation was 15 years. And 87% of them start ART while they were severely immunosuppressed. And at the time of this study, their median duration on ART was 10.5 years. The median CD4 cell count was 484, and 99% were virologically suppressed. For the quality of life, the mean physical health summary score was 55, and the mean mental health score was 58. We found that 71% of older adults had good quality of life, and 29% has impaired quality of life. The physical and mental health T-score were significantly correlated. For the neurocognitive performance, the median MOCA score was 20. There were 87% of older adults with NCI, which composed of 22% of amnestic mild cognitive impairment and 65% met the criteria for dementia. There was no difference in median MOCA score between older adults with good and impaired quality of life. The 3 domains with lowest score include language, abstraction, and delay recall. And from the bivariate analysis, we found no correlation between MOCA score and quality of life. And multivariable linear regression analysis revealed that MOCA score was associated with age, education, income, and treatment duration. The low median MOCA score and higher proportion of participants with NCI was seen when compared with previous study in Thailand. This might be explained by limited formal education in our participants and also the delay in ART initiation. We believe that apart from age and disease, the neurocognitive performance was most likely affected by the diversity in geographic, ethnocultural, and educational factors. The low domain score seen in language abstraction and delay recall didn't associated with quality of life in our participants because most of them has good quality of life, and especially in the domain of role and social functioning, the median score was 100%. Low perceived quality of life in their daily life may be due to low instrumental activities involved, as most of our participants live in their familiar community with low technology environment where high cognitive skills were not required. So NCI and quality of life were not correlated. In conclusion, we document low neurocognitive performance in large majority of older adults with immune recovery and virologic suppressed following delay ART initiation. Now that early ART initiation become a standard of practice, more research is needed to identify potentially modifiable factors affecting neurocognitive function in aging population. And early detection of NCI among this population would allow healthcare providers to monitor, counseling, or intervene in a timely manner. So that's the end of my presentation. Thank you.
Awesome. Thank you so much for a lovely talk and a lovely article. I just want to remind people, please put your questions in the Q&A rather than the chat, and we'll start answering them just as quickly as we can, and then we'll have a nice discussion about them at the end. Our next speaker will be Zara Reynolds, a research manager with interest in behavioral determinants of health seeking among people living with HIV.
Well, good morning or good evening, wherever you are. My name is Zara Reynolds, and I work with Massachusetts General Hospital. And today I want to share some of our findings as reported in our publication, Priorities for Health and Wellbeing Among Older People with and Without HIV in Uganda, which is a qualitative method study. As some background, there has been rapid growth in the aging population of people with HIV in sub-Saharan Africa, as seen in the graph below, showing the change in this population between 1990 and 2021. And as people are living longer with HIV, there's increasing knowledge about the biomedical care for this population, but very little is published on determinants of well-being for older aged people with HIV. So the objectives of this qualitative study that I'm presenting were to understand the experiences of older aged Ugandans as they define their quality of life, their physical functioning and well-being. And the results of this study informed the design of a longitudinal cohort study of the same population, which is ongoing. And the overarching goal of both studies is to understand the determinants of quality of life for older people with HIV and to guide their care. So our team conducted 36 semi-structured interviews with Ugandans, both with and without HIV, in Western Uganda in 2019 and 2020. And the themes of the interviews were guided by this conceptual framework. And the data were inductively coded thematically by 2 researchers. So just briefly, the cohort was composed, as I mentioned, of 36 participants, half among people with HIV. The median age was 57. 61% had achieved primary education or less, and the majority were subsistence farmers. So now I want to share some of the emergent themes that came from the qualitative data, and I'll present them and some illustrative quotes. And to begin, we found that overall, people with HIV did not consider their health or quality of life to be dramatically different from people without HIV as they age. As one 72-year-old woman with HIV said, HIV is like cough or flu. If you are taking your medication as prescribed by the doctor, it does not affect your way of doing things in any way. Sickness happens to those who don't take their medication very well. A 49-year-old man with HIV said, I view myself as a normal person and I would not see any change of having HIV because I don't see any difference. I have developments just like an HIV negative person, only that I see that I don't have the energy that I had before like now. A second emergent theme is that HIV stigma is reportedly declining at both the individual and community level, with the inflection point being when ART became widely available. This 49-year-old man with HIV said, honestly speaking, there's no HIV person that's treated unfairly. There is no trademark that points out an HIV person. Before, they were affected by skin rash and everyone knew the signs. Can you tell that I am HIV by merely looking at my skin? When participants were asked what conditions they are worried about developing in the future, many participants reported their primary concerns being developing uncurable, non-communicable diseases such as cancer, diabetes, and hypertension, with a particular emphasis on cancer. And respondents were also concerned about changes in physical abilities that would negatively impact social and physical functioning, such as deteriorating eyesight, hearing loss, and the loss of the use of their hands or legs. So this 57-year-old woman without HIV said, "Cancer claims lives of many people, and you hear someone saying that instead of being killed by cancer, I'd rather be killed by HIV. One says that with HIV, he or she can access any health facility and get tested and treatment accordingly and become fine. But with cancer, one has to die while in terrible pain." Overall, there were common fears around the loss of independence, both physical and financial, due to declines in cognition, energy, strength, and physical functioning, irrespective of HIV status. This 54-year-old woman living with HIV said, "I used to remove the banana suckers myself, but now I cannot. I would like to slash my compound, but I cannot manage it now. And now I have to use money to hire someone to do it. Now even raising a hoe is becoming a challenge, and I may soon fail to dig." So some key findings. A potentially unexpected finding from this work was the relative similarity in self-perceptions about health, quality of life, independence, and longevity between people with and without HIV. Declining stigma has also been reported by nearly all participants. Our data suggests that health concerns, including among people with HIV, are principally related to non-communicable diseases and health conditions that could affect older aged persons' abilities to work and socialize. Notably, we found little evidence that older people with HIV are specifically concerned about the effects of HIV on their health or longevity. Fear of the loss of independence is pervasive, and this goes hand in hand with the fear of loss of cognition and physical functioning. So the next steps for our research specifically is to conduct studies of cognitive and physical functioning, to include vision and hearing testing, which is included in our ongoing longitudinal cohort study. And also to think about the care of these populations and what HIV care programs in sub-Saharan Africa can think about doing, adding wraparound services beyond ART and opportunistic infection management to optimally care for people with HIV as they age. I want to acknowledge our study team, the participants and the staff who made this work happen, as well as our funders. Thank you all.
Terrific. Awesome. Thank you so much. Our final speaker is Katie Godfrey, an infectious disease physician with extensive experience in HIV, TB, and STIs. She is the Senior Technical Advisor for Adult Care and Treatment at the Office of the Global HIV/AIDS Coordinator, and she's published extensively on treatment issues for people living with HIV. Thank you so much.
My name is Katie Godfrey, as mentioned, and thank you very much to the organizers for giving us some time to speak. Here are my main points, and I'll just say them out loud so that if you need to take a small break, you can. So, as has been mentioned, the PEPFAR cohort is aging, and this population really is expected to grow. Mortality is higher in the over 50 group compared to all other adults on treatment, and men experience a higher mortality than women. Viral suppression is high in older adults, leading us to the inference that mortality is due to something other than undertreated HIV disease. Comorbidities are prevalent in the older population in both people with and without HIV, and we believe that treating comorbidities improves both the lifespan and the health span. Here is the age pyramid of people on ART supported by age and PEPFAR, and you can see that the largest proportion of people are over the age of 40 and over the age of 50. The largest group of people supported by PEPFAR are women over the age of 40, and with any luck, they will age into the next cohorts. And we're trying to make that happen as well as we can. So here's the group. Here are the proportions of people with HIV in green. The bright green on this slide represents the number of people supported by over the age of 50. And you can see that in some, it's different in different countries, but in some places it approaches a third or more of individuals supported by PEPFAR. And you can see that this proportion is growing. It really is growing, and sorry, this proportion really is. Oh, geez. I clicked on something to get rid of something, but anyway, is really growing, and it's expected that that by 2025, a third of the population will be over the age of 50. This is mortality data. On the left here are people between the ages of 15 and 49, and on the right are people over 50. The numbers in teal represent are men, and the number of and in gold is are women. And you can see that that men experience a higher mortality than women, both in the under 50 age group and the over 50 age group. This little bump right here, we believe, represents COVID-19, and we are hoping that this will be a temporary bump. So this is viral load suppression by age and sex across PEPFAR, and over here on the right are individuals. On the far right are people with the viral load suppression of people people with HIV. This is men over here and women over here, and you can see that the viral load suppression is better for people over 50 than in any other age group, leading us to believe that really the mortality is related to things other than HIV. These are data on the burden of disease by cause in the Africa region, and you can see that in the dark blue are non-communicable diseases. And if you add the numbers up, it really does represent a big proportion of the burden of disease in the Africa region. Here's some data from South Africa, and you can see that that non-communicable diseases in the orange have overtaken communicable diseases as a cause of death in people across all of South Africa. And thanks to Mark Seidner for pointing these data out to me. So we evaluated the prevalence of comorbidities in people over the age of 50. Going in, we thought that we would see a higher proportion of these comorbidities in people with HIV compared to those without. That's not what we saw. What we did see was that comorbidities are really common in both people with and without HIV. The gray bars are people who without HIV, and the gold bars are people with HIV. And so they're really very similar across all of these four common comorbidities. So we also looked at we did a facility-based chart review of individuals over 40 in Ethiopia. And this wasn't a comprehensive thing. The charts were randomly selected at several sites. We looked for hypertension, diabetes, and other comorbidities. And I will say that we likely underestimated the prevalence of these conditions because that data is not collected in the medical record routinely. So the important thing to say is that almost a quarter of people had at least one non-communicable diseases. I think that the jury is out with respect to whether or not comorbidities are more common in people living with HIV and without HIV. And I think probably we'll have a conversation about that in the break. But I will say that probably obesity and the metabolic disorders may be more common in women in Africa who have HIV than without. But I don't think that we can really say anything definitive about the other comorbidities. So how should we begin? Well, I will say that PEPFAR is absolutely committed to supporting and aligning resources for HIV care with national health programs and priorities. The PEPFAR strategy deliberately calls out person-centered care of an aging population. And this is what it says in the COP23 guidance. Person-centered care focuses on reducing mortality and improving the health span, the period of life spent in good health, free from the chronic diseases and aging-related disabilities. I think going forward, we're likely to focus on hypertension as a pathfinder for NCD integration. Not necessarily that we're only going to focus on hypertension, but is starting there is a way to kind of think through some of the issues about how we do NCD integration. And I will say that I think it probably looks different in different places. And again, we really do want to support national health priorities and programs. And with that, I will stop. And thank you very much for your attention.
Thank you very much for the presentation. So I think that let's spend the next few minutes having a discussion, and we'll throw this open. First of all, we'll open this up to our panelists as well as our discussants. And I wonder, as a moderator, I'm going to take the liberty of asking the first question while the speakers take a look at some of the Q&A and take a moment. And I'm going to throw this open, first of all, to the panelists as well as to the speakers. Given the findings shared by the presentations today, what do you see as the biggest priorities or maybe the most important next steps for addressing the future needs of people growing older with HIV, including both older people as well as young people coming of age with HIV?
Hi, if I could start. This is Jules Levin of NATAP in the US. And the data from the US is very clear, different than Africa, because in the US, we've had much more research and much more studies, which is one of the problems that this has not been studied as well outside the US. But in the US, it's very clear. The studies show that people with HIV suffer premature or accelerated aging. They have more comorbidities than people without HIV, for people over 50 or 60 at similar ages. They suffer age comorbidities at earlier ages by 10 to 15 years, as shown by the Kaiser Julia Marcus study at CROI 2 years ago. They suffer mortality 9 years more from the same studies. They died 9 years earlier than people without HIV. And I think everybody recognizes in the United States that people with HIV are experiencing more comorbidities, more frailty, more fractures, more falls, and that the HIV healthcare system in the United States is not prepared to deal with this, is not dealing with it. People with over 60 are not getting their care needs met. And until there's more research in Africa, we have to assume the same thing will happen in Africa. But as Katie Godfrey said, we don't know for sure because they haven't done that much research in Africa yet. So I'll leave it for that for now.
I wonder if Ken or Agri or others want to comment on, thank you, Jules, very much. I wonder if anyone would like to comment on what they see as the most important next steps. Agri, go ahead.
Yeah, I think as I'll just pick up from what Jules has said, the next big steps are really to dig down into this issue of what does aging or growing older with HIV look like in Africa, in African populations. It has been hard because it takes a little bit of different infrastructure to measure some of these things that are not uniquely or regularly supported by PEPFAR, but we have to work within our unique research capabilities to do that. And I'm happy to say that there are a couple of cohorts of which I'm part of, putting together large populations within routine HIV care. And these are beginning to take measurements. And if you will be at CROI later this month, we are going to talk about one of them called the SRN cohort. And this is within HIV clinics, both in Africa, all the way east, central, south, some parts of South America, and even all the way to Asia. And I'm part of that, over maybe 2,000 to 3,000 patients. And I think this will give us some inroads into it, but it's not easy. Thank you.
Thank you very much. I thought I maybe we'll throw the next question to Catherine, but I want to give Rena a heads up that as the following question, I wonder if there are some from the Q&A that you want to raise. But in the interim, I thought maybe we'd ask Catherine what she thinks about, given the presentation today and her work, what she thinks about whether or not there's too much focus on the 95, 95, 95 targets and not enough on quality of life and building of community and support structures for people with HIV as they grow older, or what she'd like to comment about those kinds of questions. We saw several of that in the chat and the Q&A.
Are you talking to me, Katie, or Catherine?
I was talking to Catherine, but if anyone who wants to throw in, please do.
Well, I agree. Viral suppression, at least in the United States, has been the sole driver of care in the United States. And that's not the be all and end all anymore in the context of this aging population. In fact, as Katie Godfrey showed, it's the same in the US. People over 50 and 60 have the highest rates of viral suppression. So aging and comorbidities and the worry and concern about premature death and onset for comorbidities and frailty and inability to perform physical functioning, normal physical functioning, have now become the premier concerns for the elder population. But as I said, the healthcare infrastructure is not really reflecting this problem in terms of providing for these unmet needs. And as Kate Merzen reported in her data from her interview survey study in Canada, we see the same thing in the US from studies in the US, from Bronx in New York and other places where people with HIV feel overwhelmed with comorbidities. They're worried, they're concerned about their future. They fear, they know their needs are not being met, and this is going unaddressed.
Yeah, I would just echo that. I think that we need to really start thinking about health more broadly than healthcare, and we need to start thinking about access to appropriate income, housing, especially as people's abilities change and they age with disability. I think housing is going to become even a more critical issue. I see it here in Canada, even where we have so-called universal healthcare and subsidized housing. But also thinking more inclusively about older people and the fact that they are feeling completely ignored and excluded from the HIV response as people who are well past that third 90 or 95 or whatever you want to call it. Many people have been virally suppressed for decades, and that's not their primary issue, and they feel like they have no place anymore.
Nice. Rena, were there questions from the Q&A you wanted to pull out and throw out right now?
Yes, thanks, Heidi. I think I want to follow up to what Kate and Jules said. And there was one question with regards to how do we measure quality of life and how do we monitor this? And we know that in 2021, UNAIDS had come up with a target that 90% of people with HIV have access to integrated care. Now, how do we operationalize this? I mean, it's well and good to have a target, but how do we make changes on the ground so that we can actually measure this and monitor our progress? Perhaps Katie can help address that. Are you thinking about this in the PEPFAR cohorts?
Sure, we sure are, but quality of life is a very hard measurement. And I don't know that the sort of the blunt collection instrument that is PEPFAR is really well suited to actually collect that information. I think that the longitudinal cohorts, such as Africos and the other cohorts that were mentioned by our colleague online, are really the way to go. And I am actually quite looking forward to seeing some of these. Some of the presentations at CROI. I think that we don't have a good way of measuring, of thinking through that.
I would add, as Kate Merzen found in her study, Panache, and as I see in the real world of life for elder people with HIV here in the US, many people suffer horrible quality of life. Whether it's measured or not, it doesn't matter to us. As Kate said, we feel abandoned. We feel ignored by other advocates, by the healthcare system, by the federal and state authorities. Aging has not gotten the attention it deserves. And soon it's estimated that by 2030, 75% of people in the Western world, certainly, will be over 50. Here in New York right now, 30% are over 60, in San Francisco as well. and we feel ignored, and many of us have horrible quality of life, and our care needs, the HIV healthcare clinics, the Ryan White supported clinics, are not meeting our needs. We're not getting screenings for elder people are not being done in Ryan White healthcare clinics. Bone mineral density testing, cognitive impairment testing, mobility testing are not being done, and they should be. And it's recommended in the latest IAS USA published guidelines. It's recommended they be done for people over 50, and they're not being done.
Heidi, can I just chime in and say that I hear you, Jules, and so many others who are talking about the context in, countries that have services potentially available, but they're maybe not accessible and widely available. But thinking about the context in lower and middle income countries where these types of programs are very nascent, it's hard to even know where to start. I think social security safety nets even are not widely available in a lot of sub-Saharan Africa like it is in the rest of the world. But it's hard to know where to start, where the health needs are overwhelming. Mental health support, pain management, things like palliative care, teaching people independent living skills. Like there's so many places where we could start, and that's just thinking about health in general. And then if you think more broadly about financial and food security and social contact and assistance for caregivers, like there's so many things that need to happen. It's almost overwhelming to think about.
Well, you're 100% right. And that's why we need to begin thinking about all this on a global basis. That's the point. We're thinking about it in the US. Not enough has been done. Much more needs to be done. But yes, imagine in other places like in Africa or India, where it's not even on the map yet, really, in a sense.
Yeah, I think you're raising really important points. And, I really want to congratulate the authors of these really important articles. But what I'd hope to see in the next time we do a supplement for JIS, more intervention studies and more implementation science studies, because I think we spend a lot of time talking about cultural adaptations of evidence-based practices. And I think, as Jules and others are pointing out, we have very little of that hands-on knowledge or sharing that knowledge with our peers. And, we can't assume that the same program that's oriented towards younger individuals will be equally effective in engaging people in care and providing the support and addressing all the needs that aging individuals may face. So I hope that there's such a large attendance on this call. So I hope those of you who are doing clinical research, I think the epidemiologic research using the databases is really important. I think the qualitative work, some of which we heard about today, is extremely important. But I think we want to get to the next level, which is implementation science, and really trying to figure out what are best practices to deliver the needed services for aging individuals living with HIV.
And yes, Ken is 100% right. Implementation research can be utilized in the US and everywhere to put into place programs that would address some of these issues. And I've been pleading for that for several years here in the US without much success.
Thank you, Ken and Jules. Rena, is there another question you want to pull from the Q&A?
Yeah, there are a number of questions with regards to stigma, and I think it was quite surprising with the presentation where we heard that some older people didn't feel that stigma was an issue as they grew older, and that was comparable to and it didn't impact their quality of life. But as a whole, as we think about different programs and access to care, we know that stigma is important, and it disproportionately affects people with HIV, and it impacts the access to care. As we think about integrated care for people with HIV, how do we navigate the issue of stigma? Because we would be bringing in health disciplines from outside of, with neurologists, with geriatricians who may not be otherwise familiar or sensitized with working with people with HIV. How do we integrate these services as we think about developing new integrated care for people with HIV?
One of the things that we're doing, Realize is doing, is providing HIV and aging training to service providers in the aging sector. So in home care, in long-term care, in community-based senior services. And their primary concern is always around their risk of transmission. But ultimately what we get to in these discussions is them having a better understanding of the life course experiences of people who are living and aging with HIV. And we ultimately see changes, small but noticeable changes in attitude and confidence to work with supporting people aging with HIV, just like they work with people supporting other comorbidities. So what we've done is we've been doing some training within practice professionals, but also going a little sooner and looking at pre-entry to practice healthcare professionals, whether they are nursing students, personal care aides and support workers. Some programs are looking at medical doctors as well, but we're focusing more on the hands-on care providers.
And if I could say, stigma is a misunderstood problem for elder and older people with HIV. It's not only the stigma of having HIV, which has not gone anywhere today. It still persists, and I would venture to say is not going to disappear. But older people with HIV are experiencing lots of stigma just because they're older or elderly and have HIV. And I think we need to talk about the internal and external stigma that elder people experience. Now, Kate does some work on this, and it's probably helpful. NATAP, my organization, we do 15 webinars a year. Up to 1,000 people come on our webinars. Many of them are dedicated to education about heart disease and bone disease and so forth. We reach a fraction of the patient population. I can tell you from working with people with HIV all over the US, most people with HIV don't understand what aging and HIV is really about. It's become a buzzword. Oh, aging. But they really don't understand that they're at increased risk for heart disease, fractures, cognitive impairment. They don't understand what cognitive impairment really is. They're at increased risk for frailty and for falls. Many of them don't really understand what that's all about. So I think that despite some of the great work that Kate does or that I do, and it's scratching the surface. We need federal and state and government authorities to really step up globally and in the US and everywhere to really make this a prominent, high-level, transparent issue. Not just stigma, but health and comorbidities and so forth, and care and quality of life.
Jules, as always, thank you. Having you on a panel always makes it so much more interesting and useful, and I'm appreciating that. I note that we're going to run out of time in just a few minutes, and so I wondered if Ken or Agri-Rena, any of the panelists want to have sort of make a couple of additional last words or comments about where they think things should be going. I really liked Ken's comment about implementation science, et cetera. I wonder if either the speakers or the panelists have any last comments. Go ahead.
Yeah, I would say that for the situation in Africa, we need more information. I'm part of a couple of study groups, and I would say for certain that there is a cohort looking at older people, and I actually forgot to talk about one right at my institution, and we have enrolled over 500 of them, and we're looking at them, and there's some across Africa. There's a group we had forgotten to talk about. These are the young children born with HIV, and they are growing older with it. Some of them going to adulthood, and we don't understand the different stages of life and how that being born with HIV and growing up with HIV means to them. So I know groups that are looking at cohorts following this up and also understanding mental health and all the other neurodevelopmental challenges they are going through. So these are groups where we need information. And when you talk about implementation science, yes, we will implement, but context, as usual, is always critical. So this is what I'm trying to say, that maybe some of the regional or local relevant studies will help us understand context. Thank you.
one quick comment, shameless plug. I think there's a real appetite on the part of journals to get more information. So those of you who are researchers really would encourage you to put your effort in this area. I think there's a real need to expand our knowledge pool and to be able to disseminate best practices. JIS is certainly interested in this work.
And I think it's important to add to the discussion, let's not forget that in the United States, HRSA is launching 10 aging clinics at 10 sites in 10 different cities, which will probably amount to somewhere around 2,000 people. In New York State, that was a $10 million project. In New York State, they just announced 10 such clinics as well at 10 different sites in New York State for 5 years for a $20 million program. And the HRSA program was for 3 years. And in New York City announced 3 such clinics last year. So it's a total of 23 clinics, probably serving several thousand people. But there are over 200,000 people in the United States right now over 60. So 95% of them are getting no aging or elder care screenings or care. And that's what the context of all this is.
Thank you so much, everyone. This has been, as always, a great group of people to work with. I'm so grateful for the people who contributed to the supplement and to JIS for making things easy and smooth and making everything work, and for such an interesting group of speakers, panelists, and people engaged in asking great questions. So, as always, thank you very much.